this is Roger Green, host of the Surfing the NASH Tsunami podcast. Today and tomorrow, we were offering 5 conversations from episode 25, our same-day coverage of the NICE guidance on use of FibroScan to detect advanced fibrosis and cirrhosis outside specialist and secondary care settings. This conversation continues focusing on the concerns around appropriate data collection and analysis to learn the best path forward. Will Alazawi describes the need to collect the kinds of data that will assess the value of the process and the right way to execute as processes are built and implemented. Vanessa Hebditch agrees, but asks that we not let the perfect be the enemy of the good, and that we keep in mind how many patients with advanced fibrosis are not getting diagnosed today and need the support of this program. Her dialogue with Will, which continues for a few minutes, demonstrates how pivotal it will be to balance the needs of patients who have the disease that must be discovered with researchers who want to demonstrate the value of the new process. One point that clearly emerges is that other countries will look to NICE and the UK experience to make their own decisions. This only amplifies the need to collect data well and wisely. Louise Campbell agrees and states that she would also like to see data about the effect of this initiative on related metabolic conditions, likening FibroScan scoring to dropping a pebble in a pond and wanting to explore the ripples it makes in related diseases and conditions, mentioning specifically endocrinology and cardiology. I remark on how refreshing it is to hear a conversation where multiple stakeholders align to find the best approach to the disease. I contrast this to the role of ICER, which supports a specific stakeholder group and its needs. I also ask questions about Louise's pond metaphor and mention comments Stephen Harrison and Mazen Noureddin made last fall suggesting that FAST may be a better first-line test. Will slows me up, suggesting that many questions need to be answered before we get to determining the accuracy of the tests or what the best way to perform them is. He also notes that AST is not available to primary care in the U.S. and is not likely to become so, thus making a FAST analysis unlikely. As I noted at one point during the podcast, Jeff Lazarus reported back in 2021 that the UK scored higher than any other country in its preparation for the NASH pandemic, although it scored only 50 points on a 100-point scale. The joint NICE guidance and NHS funding initiative have the potential to boost that score significantly and start to build a demonstration model for other countries. Done right, it's an exciting prospect, if a challenging one. So just sit back, listen, enjoy, learn, visualize what this could be, and when you're done, join the conversation in our LinkedIn discussion group.
William Alazawi.
Big decisions are going to be made on this. Actually, if you think about it, you've got I think, and I say this to my patients, the FibroScan is not a substitute for a biopsy. Essentially, I'm flicking the side of your skin. I'm listening to see how quickly or how loudly I can hear what comes back. It's not a measurement of scar tissue. It's a tool. It's a surrogate. We are running the Prelude 1 study now. So it's interesting, people say there's no data. Actually, we're collecting the data. We're presenting the first tranche of the data at ICER. So we've gone into 10 GP practices and we have added the FIB4 score to the diabetes annual review. And based on that, half of the practices are then referring their high-risk patients through to have a FibroScan in their local hospital, whether it's at the London or in Bristol. And the other half are being scanned in the community. Okay, so they're being scanned in the GP practice. I've got the baseline data that we're going to be presenting, and surprise, surprise, there are very few FIB4s being done in diabetic patients in primary care. That's the headline. But what we're waiting to see now is feasibility and acceptability of uptake of that second test, the FibroScan, comparing primary care with secondary care. One could hypothesize lots of things either way, and I don't want to second guess the data. We're going to get our first tranche analysed in the next couple of weeks. That won't be in time for EASL or possibly ASLD. But that's the sort of evidence you need where you have you've got a parallel thing going on, and we'll have that data, as I say, in the next few weeks. But there's an awful lot to get right. And actually, as a community, we need to get that right, because if we don't get it right, then the slight buy that we've been given based on current data will come back to bite us when we go back to ask for the next thing. So we've got to get it right moving forward.
Vanessa Hebditch.
I couldn't agree more, but I also do think that there's a balance, and I'm a great believer in not letting the perfect get in the way of the good. And on the nurse-led helpline at the British Liver Trust, we constantly hear those stories of people who are diagnosed so late. As we know, collecting evidence, doing RCTs, all the rest of it takes such a long time. And we hear from these heartbreaking stories from patients. So if we could get something for the moment that's 80% right, and then be testing and getting the data and seeing what, making sure that we are measuring and we are seeing what works and what doesn't work and what the cutoff should be, etc., that's fantastic. But I don't think we can sit back and not do things because of the devastating impact for those people who are diagnosed so late with cirrhosis.
no, I mean, I don't think anyone's suggesting that at all. I think it's just important that as a community and people listening to this podcast, it's really important that we have that balance to say it's not right yet. And we see this all the time. New drugs are licensed, new drugs are approved, and we say, look, that's a great advance for the patients. But we don't ever think that we've dealt with it, and the next drug, the better drug, is coming along. There's only a handful of medicines where actually something is so good that it stops development in its tracks. The challenge, though, is for the community to take the positives, but not to let that inhibit the academic pursuit of finding that better way of doing it. And I think there probably will be better ways of doing it. One of the things we're going to need to look at, for example, and I think, Louise, you mentioned it already, what's the DNA rate going to be? People don't turn up to GP appointments all the time. So we need to capture these things. And one of the things about NICE, one of the great things about NICE, is because of the rigor, because of the wide input that goes into it, the patients, the public, the various stakeholders, other countries look to us as well. So other countries will look at NICE and they'll say, well, actually, let's implement that in our territory also. So I think as a community here in the UK, we're going to take this, we're going to run with it. We're going to need to collect that data really, really carefully. And that's going to be the work of the early detection SIG, the NAFLD SIG, all the Basel groups to get together. And we've got this wonderful network. I don't know, Roger, if you've discussed the Torch network here in the UK. In fact, I've already broken one of the rules of the Torch network, and I'll tell you what that is. So the Torch network is the trainees in hepatology have got together and they have their own research network where they can run studies across the whole country. The reason I've broken the first rule is that nobody tells the Torch network what they should be researching on. The trainees originate their questions themselves. But one might suggest that there are certain things that various people could research in this space. So I think we need to do this, and we need to do it right. We've been given this wonderful opportunity to use essentially a second-tier test in primary care. We should use that opportunity, I think, to generate some really useful data.
Louise Campbell.
Oh, absolutely agree. And I think the other data I would like to see looked at is the endocrine data and the cardiovascular data that comes from changing these people's pathways if we can change their behaviour. One of the things that we all agree on is that a FibroScan is a behavioural change for a lot of people. You can't drop a pebble in the water without making ripples. So by doing the FibroScan test, that is the drop of the pebble, and each ripple out will be something that is changed from that one test. Now, whether or not I change getting 92% of everybody we received at Imperial for abnormal liver function test got straight back to primary care. What we want to see in the secondary care location is the right people to see specialists to get that early intervention. What we want to keep in primary care are the ones who've got abnormal liver function tests who wouldn't necessarily need to see a consultant hepatologist or potentially a tier system where you can have a virtual conversation. That's what COVID has enabled, to be able to have that dialogue. Are we struck to be able to do that? No, I don't think we are. I don't think we can put the tariffs or the reimbursement in for that yet, but it will be coming, and I think that's key. But I think it's not just the liver data that we need from this. It is the buy-in from our other colleagues, because if we stop somebody's fatty liver today, their cardiovascular risk drops and their type 2 diabetes risk drop. Does their pre-diabetes status change? Those are the other aspects of what this potential rollout could mean. But we really, as William says, we all agree that we need to collect that data, and there is massive amount of ability to research and evidence-based now how liver early detection changes chronic disease management by just getting this into primary care.
And I think that's right, but we need, and I think what you said, as in it might, and so we need to show if it does. I like to start from an agnostic position and say, well, look, we don't really know this yet, and I think this is our opportunity. But it's more than, I would say that the immediate benefit goes even beyond what you've just said. We're talking about it. It's going to be in Parliament tomorrow. There's a nice document that people will debate. They can agree with it and disagree with it. We can pick over it. But the point is that it exists. And by existing, you get debate. And by debate, you increase awareness. And you can take a pro or a con. You can think this bit's good, that bit's bad. But ultimately, you can't unknow that you could now test for liver fibrosis, both tiers, in primary care. That's the win.
Roger Green.
So, Will, I think that's one win. And as an American, I have to tell you, this is an amazing conversation, because we talked about this a couple of months ago when we talked about the ICER document on obeticholic acid and resmetirom, that ICER, which is the closest thing we have to NICE in the U.S., was put together to help insurers fight against paying for high-cost drugs, right? So instead of being a unified effort to take opinions from all stakeholders equally and make a decision that will guide the best medicine possible for the country, it becomes a stakeholder ploy. So we don't have this. But as I listen, the other thing I'm confident of is wider distribution in of itself creates more data and better answers and more questions. So simple answer. Louise says you drop a pebble in a pond, right? We believe loosely the pond is something called metabolic disease. But exactly what's the first ripple, the second ripple, the third ripple? Do they all ripple together? Is the pond circular, or is it more like a rivulet or stream, if you will? We have strong beliefs about that, right? But we don't know. So that's one thing. The second thing is we had a couple of episodes last fall where Stephen Harrison and Mazen Noureddin came on and suggested that FIB4 as a frontline test was not adequate. They went back to some of the resmetirom trial results and demonstrated how many people were getting missed in clinical trials by using FIB4 as the first screen. Now, FIB4, that's an enriched positive population, and FIB4 is appropriate in a minimal positive population, like the main population. But their point was that if they had their preference, the first-line test they would be recommending was FAST, FibroScan AST. And you'll now have the opportunity in the UK to sort some of that out, which no one's had the ability to do yet.
So hang on. So first of all, this will be what we're talking about, being able to sort this out. I think we need to be very, very clear, and you've touched on it there, Roger. You've got to be very clear as to what your goal is and what your starting population is. I would argue that even FibroScan itself, which feels like a tool, it's a box, it's used unchangeable because the thing works in the box, even the characteristics of the test are going to be different in people with different types of disease. So the test characteristics are not constant. Moreover, the pre-test probability in the different populations is not constant. We need to understand, even before we get to those, what's the best test to use, we need to get to who's going to use it. Is uptake going to be the same in all socioeconomic areas of the country? Is uptake going to be the same in all ethnic groups? Is feasibility going to be the same in one part of the country compared to another part of the country? So I think these are the big sort of geographical questions we need to ask first of all. Then you've got the issue of accuracy, and the question about accuracy is accurate to what? When you're talking about a trial population, you're really focused on, I want to find F2, F3 with NAS 4 and above. That is a goal. That's a really important goal, but it's not necessarily the goal of early detection of liver disease, where what we're really looking for is people with significant fibrosis. We don't really care if there's a ballooned hepatocyte there or not. Mm-hmm. What we care about is you've got advanced liver disease, you need to be in a surveillance program, you need to have more enhanced learning pointing towards the British Liver Trust website, etc., because that's how we prevent the cancer, prevent the decompensation. Okay? So enriching for that, so we've got to see what our goal is. The other thing to say is that by having the FibroScan, we still need to do all the other work, and it's a tool, it's a platform. You talk about FAST, okay? There are no ASTs requested in primary care.
Yeah, I'm aware of that. In fact, if one of those listeners of this podcast knows that every time I've got non-U.S. guests on, I beat the drum about what can you do to make AST and ALT more required tests in primary care. Totally aware of that.
But you're not going to get both. So the idea that you can necessarily change all primary care habits all in one go, I think we're a long way away from there. But clearly, having the guidance is our starting point. It's like the starting gun has just been fired. And yes, we can get through all of these things. And of course, behavior will be changed, as in healthcare behavior will be changed by having a drug.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded the conversation, or send an email to questions@surfingnash.com. Next week, we continue our EASL Congress previews. Until then, stay safe, surf on, and we'll see you on the podcast. Bye-bye now.